So good evening, doctors. I, Shumon, on behalf of Shield Healthcare, welcoming you all in this TNFOG Bodhana PG case discussion. I welcome all the delegates, professors and dignitaries. And today's topic is cancer cervix. And it's my honor to introduce Madam Dr. S. Sampath Kumari, Madam. Although all knows very well to ma'am, but it's my formal responsibility to introduce her. Madam is the Chief and Head of the Department, Muthukumaran Medical College and Research Institute, Chennai. Madam is the Vice President-elect FOXI 2022. She is the Founder Secretary TNFOG, National Correspondent Editor GOGI. And she is the Senate member, Tamil Nadu Dr. MGR University 2001 to 24. She is the Chairperson FOXI Adolescent Health Committee 2016 to 18, and I Director and Professor OG retired Institute of Obstetrics and Gynecology, Madras Medical College, and Madam was the President Board of Studies Obstetrics and Gynecology, Tamil Nadu Dr. MGR Medical University in the year 2015 to 19, and she is the member Board of Studies OG Meenakshi Medical University, and she is the ICOG Governing Council member from 2015 to 20. Apart from that, Madam received many awards, out of which I am a Doctor's Day Award from IMA Tamil Nadu State Branch, FOXI Dr. Durusha Distinguished Community Service Award, FOXI Mr. N.A. Pandit and Mrs. Shailaja Pandit Women's Empowerment Award, Karnavir Chakra, 15 National Award for Adolescent Activities from ICONGO. And apart from that, in academic activities, Madam written many chapters and books in FOXI textbooks, FOXI Focus and newsletters also. So with the short introduction, I hand over the session to Madam for further proceedings. Thank you very much, Madam.
Thank you, Suman. First of all, we should thank the Shield for our Tamil Nadu Federation of Obstetricians and Gynecologists, that is TNFOG. We are conducting the Bodhana class for PGs. Every month, last Saturday from 5:30 to 7, we are doing this. So this is our 11th class. In this, we select the colleges and PGs will be presenting from a single college with the 2 internals, and we select the external teachers from outside, whatever it may be in the state or outside the state. Today, we have Dhanlakshmi Srinivas College from Trichy, and the internal teachers, Dr. Bama and Dr. Aarti, and external being Dr. Sumati from KGH and Dr. Jayshree from Pandi. Today's topic is cancer cervix. Today's coordinator is Dr. Kalpana. I welcome Kalpana and I hand over the mic to Dr. Kalpana. Kalpana, you can take over.
Thank you so much, ma'am. It's my pleasure to invite you for the 11th Bodhana program, which is a great initiative by Sampath Kumari ma'am, Secretary TNFOG, and Anjalakshmi ma'am, President TNFOG. We have been doing it very successfully, and today's presentation is on CA cervix. We have learned teachers, experienced teachers to guide the students, which will be really helpful for the students during their examination. It's my pleasure to invite Anjalakshmi ma'am, who is the President TNFOG. Anjalakshmi madam's profile, please.
Is that okay? You just tell TNFOG.
Anjalakshmi madam is the founder president TNFOG, past president OGSI, governing council member DIPSI. She has got PhD in pregnancy diabetology from MGR University, recipient of Best Doctor Award, retired professor from Madras Medical College, and presented many papers in national and international conferences. And she has done extensive research work in GDM, diagnostic test, and OHA in GDM. Over to you, ma'am, for your welcome address.
Thank you, Dr. Kalpana. Good evening, everyone. I welcome the teachers, so the experienced teachers, both internal and external, Dr. Sumati and Dr. Jayshree, the external teachers, and Dr. Bama and Dr. Pillai Aarti, the internal teachers, for the Bodhana class on cancer cervix. I invite and welcome all the delegates, that is the postgraduates, both the degree as well as dependent students, and I request them to concentrate on this subject and learn. Once you learn well about the CA cervix, then that means you have half learned the gynecology and 3/4 of a gynec oncology. Okay, and a few things I want to tell about CA cervix. It is one of the 3rd generation sexually transmitted disease, which we can almost eliminate by the screening methods and the proper examination. And now the people are blessed to have the vaccine for this disease. So with this, we can almost eliminate the disease. Only thing, we have to put all these things into practice, which we are lacking. The Western countries, I think, they have almost eliminated the cervix, and this cancer endometrium is the dominant one there. So I request all postgraduates to learn nicely. If you have any doubts, please clarify all your doubts. And this is the forum where you can clarify all your doubts and learn about the cervix, which is an important topic both for the theory as well as for the practical examination. With this introduction and welcoming both the internal and external teachers, I hand over the mic to the teachers for the class. Thank you.
Thank you, madam.
Thank you, ma'am. It's my pleasure to invite Bama Ramesh, ma'am. Profile, please. Who is a professor, Dhanalakshmi Srinivasan Medical College, Perambalur, from 2019. She has been graduated from MMC and retired as professor from KAPV Medical College, Trichy, and madam's interest is high-risk obstetrics and teaching. Welcome you, ma'am. It's my pleasure to invite Dr. Pillai Aarthi Karnanidhi, ma'am, who is a professor, Department of OG, Dhanalakshmi Srinivasan Medical College. Madam's interest is laparoscopic surgeries, infertility, high-risk obstetrics. Additional role handled are ethical committee member. She was an ethical committee member, gender harassment committee member, sexual harassment committee member. Presented papers in national and international conferences. Welcome, ma'am. It's my pleasure to invite Sumati ma'am, who is a professor, Department of OG, Institute of Social Obstetrics and Government KGH, with huge experience, 30 years of experience in government service, 25 years of experience in the field of obstetrics and gynecology. She has been a teacher, UG and PG teacher for more than 20 years, master trainer in emergency obstetrics, specially trained in colposcopy. Madam's interest is cancer screening and social obstetrics. Welcome you, ma'am. Our next teacher is Jayashree Manika Vasagan, ma'am, who is a FOGSI certified advanced madam is a professor, deputy medical superintendent in Sri Manakula Vinayagar Medical College Hospital, Pondicherry, with teaching experience of almost 16 years. Madam's interest is infertility, adenomyosis, simulation in medical education. Welcome you, ma'am. Our presenter is Gauri Manoharan, who is a second year PG in Dhanalakshmi Srinivasan Medical College, Perambalur. Welcome, Dr. Gauri. Our next presenter, co-presenter is okay. Teachers, you can take over. You can tell the presenter to present the case.
Yes, ma'am. Dr. Gauri, you can present.
Dr. Gauri? Yes, yes.
Kalpana, we have 320 registration. So 320 PGs are watching this.
Good evening, ma'am.
Yes, ma'am.
Ma'am, is my screen visible, ma'am?
Yes, yes.
Yes, ma'am.
Good evening, ma'am. This is about the details of the patient, ma'am. My patient, Mrs. V, who is 37 years old, who is a Hindu by religion. She is para 3, living 3 with abortion 2, and she was hailing from Kadalur district. She was a widow. Her husband expired 7 years ago, and she is a coolie by occupation, and she belongs to lower socioeconomic group. Chief complaints. She presented to us with complaints of profuse on and off white discharge PV, which is also associated with the history of postcoital bleeding for the past 6 months.
1 minute. So what do you think is the cause for profuse white discharge on and off? And now you say she's a widow and she's having a postcoital bleeding also.
Yes, ma'am.
Okay.
Yes, ma'am.
What do you think are the causes?
Ma'am, when asked about the history, ma'am, she gave the history of sexual promiscuity, ma'am, and also this because which is a risk factor for CA cervix. My first diagnosis goes with CA cervix, ma'am.
Okay, can it be only CA cervix? Tell me what are all the differential diagnoses you
Yes,
get in
ma'am.
a
Other differential
person
diagnosis.
in the reproductive age group.
Yes, ma'am. Other differential diagnosis could be candidal infection. It could be trichomonas vaginalis. It could be bacterial vaginosis, ma'am, or it could be any infected polyp.
Okay. Okay.
Ectropion, endometritis.
Okay, proceed. So these are the differential diagnoses which are there in the mind. At the back of the mind, you also have the CA cervix. Okay.
Yes.
Okay, proceed.
Yes. History of presenting illness. Patient was apparently normal 6 months before. She started having foul smelling, copious, dirty, white discharge PV over the past 6 months. History of extramarital affairs after the death of her husband. She also gives history of postcoital bleeding, which was initially less in amount, but since past 2 months, she has profuse bleeding after each coital act. History of dyspareunia present. History of intermenstrual bleeding was there. History of diffuse lower abdominal pain, which is sharp in nature and severe in intensity, which was relieved by over-the-counter medications. The history of loss of appetite was there. Anorexia was present. History of excessive tiredness and breathlessness on exertion was present. History of on and off palpitations was also present.
What are the other negative history you'd like to ask?
Ma'am, the other negative history, there was, she did not, I asked about whether she could feel any mass per abdomen or whether there was any abdominal distension. There was no history of any such things. She changed per day and it was an average flow. Marital history, she's married at the age of 16 years and her husband expired 7 years ago. She's no, but presently she's sexually active by sexual promiscuity. Obstetric history. Her parity index is para 3, living 3 with abortion 2, and her last childbirth was 16 years before. All were full-term normal vaginal delivery, and she was sterilized 12 years before. No history of hormonal contraceptive usage in the past. Past history.
What's
She's
the
not.
relationship with contraception and carcinoma of the cervix?
Ma'am, when using contraceptive, the estrogen in the contraceptive pills, this could cause ectropion, ma'am. So the cells will be exposed more to the environment, ma'am, to the acidic pH, ma'am. So metaplastic cells will be more, so the risk of CA cervix will be more.
Okay.
Past history, no, she's not a known case of any chronic diseases. No history of previous blood transfusions. Family history, there is no history of gynec or colon malignancy.
What other history do you like to have?
Past history, ma'am.
No, because you said that she has got sexual promiscuity. Would you like to ask about anything about the immunocompromised state of the patient?
Yes, yes, ma'am. First, we have to ask about whether she is, since her husband expired, I asked about the history of how her husband expired, whether there was any immunocompromised condition in her husband, ma'am, and that any sexually transmitted diseases was present like HIV or AIDS. And
Okay.
whether
What
she's
is the relationship? Okay, what is the relationship of HIV and carcinoma of the cervix?
ma'am, HIV is an immunocompromised state, ma'am. So in this state, human papillomavirus coexist. The infection will be coexisting, ma'am. So in patients with HIV, the screening modalities all should be done in frequency more than nearly twice as common as in the common public.
Okay, okay, go ahead.
Family history, there is no history of gynec or colon malignancies in the family. There is no history of any chronic illness among the first degree relatives. Personal history, she takes mixed diet. She complains of a decrease in her appetite, normal bladder and bowel habits, normal sleep pattern. There is no history of any addictions. Summary, she is 37 years old, para 2 living to abortion 3, who belongs to the lower socioeconomic group, who has extramarital issues, has presented with complaints of white discharge PV and with history of postcoital bleeding for the past 6 months, and also history of excessive tiredness and breathlessness on exertion and loss of appetite. General examination. Patient was averagely built and nourished. Her height was 156 centimeters and weight was 50 kgs. Her BMI is 20.5. She is well cooperative. Her general condition was fair and the pallor was present. There was no icterus, cyanosis, clubbing, lymphedema or any pedal edema. There was no palpable neck nodes. The thyroid is normal and breast examination was also normal. Vitals. Her pulse rate is normal and BP was 170, temperature was normal, respiratory rate is 18 per minute. Systemic examination, all central CVS, RS, CNA, no abnormality was found. And on per abdomen, on inspection, there was no abdominal distension. All 4 quadrants moves equally with respiration. Umbilicus was in the midline, inverted. Sterilization scar was present. Hernial orifices were free. There was no skin changes, no visible mass, no visible pulsations or engorged veins. There was no sinuses. On palpation, there was no warmth. It is soft for palpation. Tenderness was present over the
When did
supraphysial.
you have a mark?
Ma'am?
When did you have a mark over the abdomen in a case of a CS cervix?
Ma'am, in a case of a CS
The
cervix,
patient with carcinoma of the cervix, when
yes.
you
Ma'am,
are able
in
to
case,
see the mark, what did you say?
yes, ma'am. In case of patients with CS cervix, sometimes if if it is a condition where the lower segment of the uterus is completely obstructed, it may result in pyometra or hematometra, ma'am. And so that can.
You cannot call as a lower segment. You'll have to cause, there is
Cervix,
no lower segment. in the
cervical
gynec.
canal, when the cervical canal is completely obstructed, it will pyometra and hematometra. This could be felt as a palpable mass, ma'am. Sometimes if the lymph nodes are enlarged to a large extent, it could be palpated with deep palpation, ma'am. And if it is caused, if the CS cervix has extended and causes ureteric obstruction, and if hydroureteronephrosis is present, palpable kidneys could be seen, ballotable kidneys could be palpated.
Okay, but then the patient will be in a state of uremia when the patient is
Yes.
going to have a ballotable kidney.
Yes.
Okay, proceed.
There was no guarding or rigidity, no palpable, there was no organomegaly, there was no renal angle tenderness. On percussion, tympanic sound was here. There was no shifting dullness or fluid thrill. On auscultation, normal bowel sounds were here. Local examination, external genitalia appeared normal. In the perispectrum examination, I could see a proliferative
Inguinal nodes. See
Yes.
whether there are any nodes in the inguinal region also.
Okay. A proliferative friable cauliflower-like growth approximately of 3 cross 3 centimeter was seen arising from the posterior lip of the cervix and which extends to the medial aspect of the upper part of posterior vaginal wall, and lower 1/3 of the vagina was normal. In the bimanual examination, I could feel a friable growth which bleeds profusely on touch, and it was felt arising from the posterior vaginal wall, extending to the arising from the posterior lip of the cervix, extending to the posterior vaginal wall. Fornices were not involved, and it was free, and the uterus was normal size, anteverted, and it is mobile. Per rectal examination, I could confirm the size of the growth. Rectal mucosa was free. Parametrium was also free. There was no induration or nodularity felt.
Do you confirm the size of the growth per rectally?
Ma'am, if it is if it is an endocervical CA, in which we cannot we cannot see the mass outside, that could be confirmed by rectal examination, ma'am. Since this this is
Here, this patient, see, in this patient, you saw a growth in the posterior lip of the cervix. So you did not say that the size of the growth is confirmed by doing a per rectal examination. Just say about the how the rectal mucosa is. Rectal mucosa is supple.
Okay.
Okay. Next. What are the other findings you said?
Parametrium. Parametrium was, I could not feel any nodularity.
Okay.
Provisional diagnosis.
What was the extension of the parametrium? Extension of the parametrium? There was no rectal parametrial involvement.
Yes, ma'am.
There was no parametrial involvement.
There was no parametrial.
Okay. Okay.
Provisional diagnosis. Yes, ma'am.
Yes, continue.
Mrs. V, 37 years old, para 3, living 3, abortion 2, presented with copious white, foul smelling, white discharge PV associated with postcoital bleeding for the past 6 months. On examination, she was pale, her vitals were stable, her abdomen is soft. Perspiculum examination revealed approximately 3 cross 3 centimeter papillomatous friable growth from the posterior lip of the cervix, extending to the posterior vaginal wall, which was bleeding profusely on touch. Uterus was normal in size, anteverted, mobile. Rectal examination shows bilateral free parametrium. Rectal mucosa was supple, and this suggests a clinical staging of stage 2A1 CA cervix.
What are the differential diagnoses?
The differential diagnosis could be, it could be a TB, ma'am, in this, and also it could be a syphilitic ulcer, condyloma acuminata.
Okay. So you just tell it could be probably a carcinoma cervix, but anyhow, I would like to confirm it with biopsy. Even with the tuberculosis of the cervix, though it is not very commonly seen, you can also have such a clinical picture, and we would always like to have a biopsy before we confirm it as a carcinoma of the cervix. Okay.
Yes.
Okay. Madam, there's one more examiner, no? Sampath, who is the other external examiner, ma? Somebody from Pondi is there, no?
Dr. Jay. I'm here. Now only I could unmute. Actually, previously I was not able to unmute. That's why I could not join you.
Welcome,
Okay,
ma'am.
Okay, you can, ma'am, you want to ask questions because I was just interfering in between. If you'd like to ask some questions, please, ma'am.
No, ma'am. No, ma'am. I mean, you are going in that continuation. Continue, ma'am. Continue.
No. You can also ask if you want.
Yes,
because
ma'am. Yes, ma'am. Yes, ma'am. Sure, I will ask. You told nodularity, no? Okay. Usually we see induration, right? Do we see nodularity?
Covering.
Cervical cancer.
Yes, ma'am.
We say indurated.
Okay.
Or you told nodularity. You are not able to feel any nodularity. So usually we see parametrium is indurated, right? And how
Yes,
do you,
Why,
yeah,
if you want to say the findings on per rectal examination, you say whether rectal mucosa is free or it is puckered. Parametrium is free or indurated, or whether parametrium is sub.
yes, ma'am.
Rectal mucosa is free or whether it is puckered with involvement. When you come to parametrium, indurated parametrium, and also nodularities usually we say in case of endometriosis, not in cases of in
Yes.
endometriosis, we can have nodularities. Here it is indurated one. When the
Okay.
parametrium is free, you can say supple parametrium.
Okay.
So these are the terminologies to be used. So how do you go about? How do you go about this case?
Yes, in this case, we have to proceed with pathology, ma'am. So we go in for biopsy of the growth, ma'am, and it was proven to be squamous cell carcinoma.
And no, but that we will tell.
Yes, ma'am.
Whether the biopsy is squamous cell carcinoma or other things is there. I just say you are taking a biopsy
Biopsy.
and you are going to send for a histopathology examination. Okay, it's going to come as a, as you said, it's going to be a squamous cell carcinoma. Okay, how will you go about? Now this patient, you have seen her clinically, you're taking up a biopsy and sending it to pathological department. Okay,
Yes.
will you keep her as a OPD or will you admit her in your hospital if you have such a patient?
Ma'am, this patient, since even during doing the PV, it was profusely bleeding, ma'am. So I would like to admit this patient, ma'am, and also clinically she was paler, ma'am. So in case if she bleeds profusely after biopsy, so for management and for further blood transfusions, I admitted we admitted the patient.
how will you stop the bleeding in biopsy? TA cervix.
Yes,
If the
ma'am.
patient is bleeding profusely.
Yes, ma'am. After taking the biopsy, packing the vagina tightly would stop the bleeding, ma'am. In case even after that, if the bleeding is not stopped, then we can apply Monsel's paste, ma'am, which is ferric subsulfate.
Monsel's paste over the cervical growth, it will not be very helpful, ma'am. So
Yes.
what is Monsel's paste? What is it?
It's ferric
It is like a
subsulfate.
chemical cautery. It is like a chemical cautery. Can you
Okay.
apply cautery over the growth and stop the growth? I mean, bleeding.
Yes.
It's very difficult. If it is, most of the time it stops with just the packing alone.
Yes.
If it is profusely bleeding and not, if you're not able to hold, that is very rare. Usually you have such severe bleeding, especially in gestation trophoblastic disease where they have secondaries. That time you can have some severe bleeding where the people go in for hemostatic radiotherapy. Hemostatic radiotherapy is given in such cases, but we have hardly seen such cases. We have read about it, but many a times it is just the packing alone. It will be helpful in stopping the bleeding. Okay, this patient is admitted. You are giving her blood. You are improving the general condition. This comes as CA cervix. You have already staged clinically with the CA cervix stage 2A1 cervix. Now, how will you stage carcinoma of the cervix? And how will you stage this patient and how will you manage this patient?
Ma'am, carcinoma of the cervix is
Carcinoma of the cervix. Normally, how do you stage carcinoma of the cervix?
ma'am, by clinical examination, ma'am, and according to the FIGO 2018, now radiological and pathological is also included in the staging, ma'am.
Okay, what is the older staging? What is the later stage? And what are the differences?
Ma'am, older staging was FIGO 2000.
Grossly you just say, and minor details you just explain.
Yes,
Grossly you just give.
the older staging, the radiological and pathological findings were not included in the staging. It was only clinical staging, ma'am. Now, radiological and pathological also it's included in the staging. And previously, the extent of the lesion was also included in the staging, ma'am. Now it is only the depth of invasion is included in the staging, ma'am.
What do you mean by depth of invasion and what did you say? Come back again.
Extent of the lesion.
What do you mean by extent of the lesion and what do you mean by
Extent
the depth of
means the extent of the growth, ma'am.
What do you mean by that? You are not very clear about it.
Initially, the extent means the size which we.
No, that is in early stage, is it? In stage 1, you are saying?
Yes, ma'am.
1. So stage 1, how do you stage in stage 1 in oldest, 2009, 2008 and 9, you had the staging, no? The earlier staging. What is stage 1?
Stage 1 is the which is involves only the cervix. When the disease is when carcinoma is involving only the cervix, ma'am, not extending to uterus.
Okay. And how do you divide stage 1?
Stage 1 initially
1A,
1A and 1B, ma'am.
1A,
1A and 1B. In 1A, it is 3 divisions from 1A1, 1A2, and 1A3, ma'am.
that is the latest. Or the older one. Okay, 1A1, what is 1A1?
Ma'am, 1A1 is
What is 1A1?
Ma'am.
Yes.
1A1 is less than 3 mm.
And
1A2 is.
Yes, continue.
1A1 is yes, ma'am. 1A1 is less than 3 mm. 1A2 is 3 to 5 mm, ma'am. 1A is totally micro-invasive disease, ma'am. 1B is which we can see by the naked eye, and it is more than or equal 1B1, 1B2, 1B3, ma'am. 1B1 is more than or equal to 5 mm up to 2 centimeter, ma'am. Now 1B2 is from 2 centimeter to 4 centimeter. 1B3 is more than 4 centimeter, which is also which is a bulky disease. And stage 2 is when the growth extends.
Okay, Gauri, you are. There are so many people listening. People may not understand. If you are going to go into the depth, I just want to see the salient features. If you are just going to go into the people who have not read may not understand. Let everybody understand. Okay. So in stage 1 in 2000, the older stage, you had stage 1A and 1A1 and 1A2. You did not have 1A3. Is it?
Yes.
Is it so?
Yes.
What do you say?
Yes, ma'am.
No, stage 1 also 1A1 and 1A2. Okay.
1B.
No, 1A1 and 1A2.
1A2.
Only two things. 1A had 2 divisions, and that had a depth as well as a lateral extension. The older figure had a lateral extension also being mentioned. Okay, now only the depth is included. The lateral extension is not mentioned because there are a lot of artifacts in getting the diagnosis. So they are telling only about the depth and not the lateral extension in the latest figure. Okay.
Okay.
Now tell about 1B.
1B is visible disease.
1B had B1 and B2. 1B had B1 and
B1, B2, B3.
In the older one.
Older, okay.
Now you have B1. No. Older you had B1,
okay.
B2. Now you have B1,
B1, B2,
B3. Okay. That was talking only about 4 centimeters. Now you say less than 2, 3 things. Okay.
Yes, ma'am.
Less than 4 and 4.
Yes.
Okay. Yes. But now you have less than 2, 2 to 4, and more than 4. Okay. Why all these things? Just tell why all these small subdivisions.
Yes, ma'am. This is for the further management plan, ma'am. If the growth is less
not
than
only that, the prognosis is better.
Yes,
the prognosis is better if you have the lesion when the stromal involvement is less than 2 centimeters.
Yes,
when the stromal involvement is less than 2 centimeters, the prognosis is better. The prognosis is better when the stromal involvement is between 2 and 4. When it is more than 4, the prognosis is really bad. So it is stage 1. that is confined to the cervix also, you had more amount of better prognosis. When you group them, you have better prognosis. That's why we wanted to have all these subdivisions. Okay. So how is imaging? Now you told that there is imaging also included. Now this patient has come with stage 2A, where there is a growth which is less than 4 centimeters. Is it not?
Yes, ma'am.
Is it less than 4 centimeters?
Yes,
And
ma'am.
it is also involving the upper third of the vagina. So
Upper
that
third.
is why you have told it is stage 2A. Okay, it is stage 2A1, you have said, because it's less than 4 centimeters and it is involving the upper third. It has crossed the cervix. Okay, now how will you proceed? How will you use imaging now do for this patient before you manage? Olden days we were just using, not using the clinical staging itself, we were just coming into the picture. So how are you going to manage this patient? Using imaging.
Yes, ma'am. Initially, we'll go with ultrasound, ma'am. In the ultrasound, if we could see a hydroureteronephrosis, then we could suspect the lateral extent of the disease, involvement of the ureters or obstruction of the ureters, ma'am. Then and the next modality will be we can go with CT, ma'am, to look for any lymph node involvement.
Okay.
And if MRI is available for local.
Your hospital has everything. Your hospital has got everything. So you're going to order whatever investigations you'd like to do in managing this patient. Tell, what are the other investigations?
And MRI for seeing the parametrial involvement, ma'am.
Okay.
For distant lymph node metastasis and distant organ involvement, PET CT would.
So your imaging is going to alter the diagnosis, is it not?
Yes.
I mean, staging.
Yes.
Clinically, you are at stage 2A1,
Yes,
cervix, you are managed in a way earlier. Now before you, now you are having all the investigations.
Yes.
Now the investigation shows, the MRI shows there is involvement of the parametrium, but not up to the pelvic wall. Okay.
Yes.
Okay.
Yes,
then your but the lymph nodes.
Yes, ma'am.
Your CT, so CT.
Yes, ma'am.
CT also. There they say that there are nodes which are present in the pelvic areas.
Yes.
Okay. How will you manage? What is your diagnosis? How will you manage this case?
Ma'am, if initially we have made a diagnosis, we should not change the diagnosis, ma'am. If the diagnosis is not clear also, lower staging should be given, ma'am. But before the final diagnosis, if already we diagnose, then the final diagnosis should not be changed.
Yeah, it should not be changed. But now your diagnosis by you are doing an MRI, you are doing a CT, adding imaging. According clinically, it is stage 2A.
Yes.
1. But there are nodes which are also there. There are also parametrium involvement.
Yes.
Okay.
Yes, ma'am.
How will you manage?
If nodes are involved, then this will be stage 3, ma'am. So we will be going for concurrent chemo radiotherapy.
Okay. So how will you give concurrent chemo radiotherapy?
Concurrent chemo radiotherapy, in this the total radiation dose will be around 50 to 80 gyries, ma'am. This will be divided into 2, ma'am.
You'll give up to 80 gray for the growth.
Total radiation, total dose, ma'am.
Okay.
This will be divided into 2, ma'am. External beam radiotherapy and brachytherapy, ma'am. In the external beam radiotherapy, around 45 to 50 gyri will be given. In the brachytherapy, the remaining will be given, ma'am.
What do you mean by brachytherapy? What do you mean by brachytherapy?
Brachytherapy is two modalities, ma'am. Either intracavitary or interstitial brachytherapy can be given, ma'am.
Okay. What is the radioactive source which you are using for a brachytherapy? What are the 2 types of brachytherapies you know?
The two types of brachytherapy is intracavitary and interstitial, ma'am. The radiation source will be iridium, cesium, ma'am.
What is the difference between iridium and cesium? Gauri, are you there?
Yes, ma'am.
Yes. Yeah. So is there anybody else to answer? Somebody else can also answer. If anybody knows, you can just put in the chat box, or you can also answer. So the difference between iridium and cesium is cesium has got a longer half-life. So it has got a low dose radiotherapy. It's otherwise called as a low dose radiotherapy. With iridium, it's a high dose radiotherapy. Okay. When you are putting a cesium, the patient will be how will you apply have you seen or witnessed or have you seen in the YouTubes of how intracavitary radiotherapy is being applied?
Yes, ma'am.
Yes,
ma'am. We have seen.
An outpatient procedure or an inpatient procedure for cesium?
No, ma'am. We were posted in Nadia Cancer Institute, ma'am. So we saw.
Okay. So you saw. Okay. Now tell me. Because there are people who have not seen also. So you just tell how you just apply it.
Yes, ma'am. The tandems will be placed, ma'am, inside the cavity, and the vaginal ovoids will be
or without anesthesia.
Under IV sedation.
So you should tell that this procedure is done in an OT, minor OT, where they give anesthesia, and then you do the application, and after application, patient will be kept in a room. Okay, so you have a central tandem
and vaginal
tandem.
Oh,
okay. Okay.
And the after loading technique is practiced now, ma'am.
Remote control after loading technique, where they can the application is going to be the patient will have to stay depending upon the dose calculated. They might have to stay for at least 24 hours. Sometimes they have to stay for 36 hours depending upon the dosage which you are going to give. Supposing if it's iridium.
Yes, ma'am.
Iridium.
Iridium it will be like that intensity modification, ma'am. So depending on the
So you'll have to go in depth about.
Okay.
I don't want to go into the depth of radiotherapy, but you will have to have intracavity. You have an external beam radiotherapy. How do you do external beam radiotherapy?
In the external beam radiotherapy, we do it with the help of linear accelerators, ma'am. This will be done for 5 weeks, ma'am. And the total radiation will be divided into 25 fractions, ma'am. Each fraction will be given this will be given for 5 days in a week for 5 weeks, ma'am. The 2 days will the rest will be given for rejuvenation of the tissues.
Okay. Okay. Now that this patient is, you are just posting for a concurrent. What do you mean by concurrent radiotherapy? You said no.
Concurrent chemo radiotherapy is on the first day of every week. We give a chemo, ma'am. We give cisplatin 40 milligram per meter square, ma'am. This makes the tissues more sensitive for the radiation.
What are the investigations you'd like to do before giving a cisplatin? Or any radioactive, any therapy for radiation, you will be doing others list of investigation.
Will be in complete hemogram, renal function test, and liver function test.
You have to be specific about saying that I would like to do the renal function test because it's a heavy metal. It is going to be excreted to the kidneys. There can be a kidney toxicity. So when I am going to give cisplatin, I'll have to give with enough of fluids. So I will give a lot of fluids before I give this platin. Okay. Okay. Now this patient is going in for a radiotherapy, you said. Supposing this patient, when you are doing an MRI, there is no node, there is no involvement of the parametrium, how will you manage?
If there is no node and no involvement of parametrium, then we could go for radical hysterectomy in this patient.
Madam, you want to question, madam? Hema madam.
Oh, surgery, ma'am. Surgery. Can she talk about surgery? Because
Yes, ma'am.
we
I
have.
just want you to ask because I'm keeping on questioning. You can also question, ma'am. I will stop with this. You just ask, ma'am, and then I will stop. Surgical part you just ask. And
Yes,
then the
ma'am,
next
because you
part,
complete radiotherapy, ma'am, then we can go into surgery because that's why I'm not.
because I don't think we will have enough time. That's why I wanted to rush off.
Okay, ma'am. Okay.
Whatever they have a lot of other questions also in radiotherapy, but we'll go back because the other things. Okay, Gauri, what are the complications of radiotherapy? How will you monitor a patient with radiotherapy?
Ma'am, complications of radiotherapy can be divided into immediate complications and late complications, ma'am. The immediate complications, there will be diarrhea. There will be if there is infection, fever may be present. Bleeding, sometimes bleeding may be present, and in late complications, there will.
Most common complication, they'll complain of vomiting, nausea and vomiting.
Yes. Nausea.
So when you are going to give a chemo or radiotherapy, they will always give some emetic,
Anti-emetic.
responsible one response. The response will mostly be with steroids also. Many times they need to give steroids to stop because it activate the chemoreceptor trigger zone. They give steroids to stop the vomiting when this is induced with the chemotherapy or with the radiation.
Yes.
Okay.
Yes.
Late complications.
Late complications, is fibrosis, fistula formation.
Not fibrosis. They have adhesions, adhesive vaginitis.
Okay.
Adhesions, adhesive vaginitis will be there. Skin might be the skin may be becoming a scarring or the skin changes will be there. Sometimes they can have fistula. They can also have proctitis. They can have cystitis. Sometimes the patient will after long-term complications again sometimes present with bleeding per rectum. It can just be a proctitis, radiation or sometimes cystitis, radiation induced.
Yes.
Okay, these are the things which they can have, or sometimes fistula also. But these are the things which are now corrected with other newer methods of radiation where you are specific over it and avoiding all the other things. So how will you do that? How will you avoid? What are the latest advances in radiotherapy?
Conformal techniques, ma'am.
Latest advances like image guided and intensity modulation radiotherapy, IMRT and IGRT are the latest things.
Yes.
Okay. Somebody else is talking in between. Okay, supposing it's early stage, Hema madam will ask questions on the surgical management.
Yes.
Yeah, tell me which patients you will go in for surgery.
Ma'am, when the disease is in the early stage, ma'am, that is up to 2A without 1B3, ma'am. 1B3 is not included in that. Till that we can go for surgical management.
Okay. So what type of surgery will you do according to the stage of CSF?
In stage 1A1, if there is no lymphovascular space invasion, we can, if the patient wants to, if the patient is desirous of fertility, then we can go for conization, or if otherwise, if fertility is not desired, we can go for extrafacial hysterectomy, ma'am. And stage 1A. In 1A2, we can, if she's desiring of fertility, we can go for trachelectomy, radical trachelectomy, or else, if she is not desirous of fertility, we should go for radical hysterectomy. If the lymphovascular space is involved, we should go along with the lymph node dissection. Then in stage 1B, if the patient is desirous of fertility, radical trachelectomy with the pelvic lymph node dissection if lymphovascular space is involved. If she is not desirous of fertility, we should go for modified radical hysterectomy, ma'am. In stage 2, we should go for stage 2A1, we should go for radical hysterectomy.
what is the new classification of hysterectomy? We are not calling it as extrafacial hysterectomy, no?
Yes, ma'am. Now the new classification is Corlo-Moro classification.
Tell me about that. What are the three types? Type A, type B, and type
Type
C.
A, type B, and type C, ma'am. Type A is corresponding to the simple hysterectomy, ma'am. Type B is the modified radical hysterectomy.
It's not a simple hysterectomy, no? Type A. They do something different here. It's not the routine hysterectomy which we do, right? That is also called as limited radical hysterectomy. It is not otherwise called as extrafacial hysterectomy, right?
Yes.
So what do they do here? And which stage we do it? Up to which stage? So 1B1 we can do, right?
Yes, till 1B1.
Okay. So what is different from this from extrafacial hysterectomy? So you remove a part of paracervix also. Okay. And actually you have to dissect the ureter also. Okay. So ureter usually first they identify the ureter, they visualize the ureter. Okay. Yeah. Then they dissect the paracervix also. So that is not a simple extrafacial hysterectomy which we do nowadays.
Okay.
Okay. So that is type A. So what is type B?
Type B corresponds to the modified radical hysterectomy, ma'am. And type C is the nerve sparing hysterectomy.
So what are the principle of type B? Where do you place your clamps?
It will be
What
placed.
are the limits of your modified radical hysterectomy?
Yes, ma'am. And modified radical hysterectomy, the clamps will be placed the midway between the cervix and the pelvic side wall, ma'am. That is where the ureter crosses the uterine arteries. The clamps will be placed over after lateralizing the ureters.
Lateralizing the ureter. Okay. So what is type C then?
Type C, one is the nerve
And
sparing.
you include here lymphadenectomy, right?
Yes, ma'am.
So you do pelvic lymphadenectomy also, right? Okay.
It's a nerve sparing.
So what are the nodes you remove?
The totally 5 groups of lymph nodes will be removed, ma'am. External iliac group, superior groups and inferior group, internal iliac group, obturator group, and common iliac group.
Okay. What about type C?
Type C is nerve sparing hysterectomy. It's otherwise
There are 2 types, right? No sparing and no preservation.
No.
Okay. So what else we do nowadays during the surgery apart from your types of hysterectomy? Directly instead of doing lymphadenectomy, what else can we do?
I mean, if it is an early disease, then we can go for sentinel lymph node mapping, ma'am.
Okay. How can we do this mapping? What dye we use?
Indocyanine dye will be injected, ma'am.
Okay. So where will you inject and how will you inject this indocyanine green? If you're going to use a radioisotope mapping or video recording, then you will use indocyanine green. Otherwise, what else?
Otherwise, methylene blue.
Yeah, methylene blue also you can inject, right? So where you will inject this?
This will be injected near the parametrium.
Parametrium.
Paracervical.
You inject in the cervix.
Yes.
Okay. Right? You inject in the cervix. So your 2 o'clock, 4 o'clock, the same. So like that you will not at 3 o'clock and 9 o'clock. So other 4 sites you inject your dye. Yes. And what will you look and what will you do next after you inject the dye?
And the staining of the nodes will be used.
Okay.
If the sentinel node is getting stained, then we have to go for dissection and send it for frozen.
Okay. So when will you go for para-aortic lymph node assessment? Which patient?
Ma'am, only after removing the pelvic lymph nodes, ma'am, this will be sent for frozen section, ma'am. If the common iliac nodes are involved, then we should go for para-aortic nodes.
Or that your nodes are more than 2 centimeters. With metastasis, you have to go for para-aortic lymph node involved.
Yes.
Okay. What about your minimally invasive surgery for your cancer cervix?
Minimally invasive surgeries, laparoscopic surgeries.
Okay. And now we've gone one step ahead also, no?
Robotics.
Robotic surgeries, right? So that we are using only for our onco surgeries, right?
Yes.
So I think you should know about where we put the ports and all those things, how we prepare the patient. So those are the things which we should, people should know, because that may be as in a recent advances also.
Yes.
So I don't think we have that much time to include all those things. Ma'am, you can continue, ma'am. Sumati, ma'am. Some internals can also
Yes,
ask
yes,
questions.
yes, yes.
Yeah.
Yes, ma'am. Yes. Now this. Okay. Now, Gauri, we have discussed on management of the cervical cancer, surgical management, and also the management of radiotherapy.
Yes.
Okay, but we would need to have a comprehensive idea how we are going to manage. Why we have surgery? Why we have radiotherapy? Why we cannot have all the things together? What is the advantage of combining? What is the disadvantage of combining? Do you want to have both modalities or you want to have a single modality? What is the results with radiotherapy and with the surgery? What are the results? Do you have any difference in the survival rate with radiotherapy and surgery? Why we have so many advances?
Yes.
Do you have any idea why we have so many advances, so many things?
Yes, ma'am. The single mode of therapy will be more beneficial, ma'am. And in the early stages, both surgery and the radiotherapy. Ma'am?
Right. See, tell me why a single mode of therapy is beneficial.
Because the
Why we should not have multiple?
morbidity is reduced in single mode. The complications will be more if we use both modalities, ma'am. So if we use only single
Yes.
modality, the
Okay.
complications.
What are the complications? Okay. Tell me what are the complications. You
In
said
surgery, the complications are bleeding, infections, in injury to the adjacent organs, ma'am, and other late complications like fistula formations, ma'am. In the radiation, because of the effect of radiation, we have the immediate other like cystitis, proctitis, fibrosis, so all those complications will be there.
I just want you to put one case scenario. Gauri, I just want to put one case scenario so that other people are listening will understand.
Yes.
Supposing there is a person with stage 1A1. Okay, stage 1A1. Okay.
Yes.
You want to do surgery or you want to do radiotherapy?
Surgery one, stage 1.
5 years survival is going to be. Yes.
Surgery, ma'am. Surgery.
Yes, tell me.
Stage,
You
if
want
it is
to go
stage
only for surgery.
go ahead.
Okay.
Surgery, yes. If the patient is inoperable, in that case,
Yes, supposing it is stage. Am I not audible, Gauri? Supposing
Now
okay,
you are
it is just
audible,
a
ma'am. In
survey.
between, yeah, we are not able to hear you.
ma'am,
Am I not audible?
I couldn't get you. Yes, ma'am. Now
Am I
you are
audible
audible,
now?
ma'am.
Okay. Supposing there is a person with stage 1B. Okay. She is going to be an ideal candidate for surgery.
Surgery.
Will you opt for surgery or for radiotherapy?
Surgery, ma'am.
You will opt for surgery.
Yes.
Supposing the nodes are coming as positive, what will you do?
If the nodes are coming as
you are doing a radical hysterectomy, and then you are finding out you are picking up the nodes. The nodes are going to be positive. What will you do?
Ma'am, if They are depending on the Park's criteria and Siegel's criteria, we'll decide whether to give a post-op radiotherapy or not.
Okay, now the nodes are positive. What are you going to do? I'm just asking. What criteria are you going to use and do it?
Yes, ma'am. If the stromal invasion is more than 50%, if the nodes are involved, then we have to go for post-op radiotherapy.
Okay, you need to have an adjuvant radiotherapy, is
Yes.
it not?
Yes.
So if you want to go to have an adjuvant radiotherapy, what are the disadvantages? Because you are using a dual modality. You have already done a surgery. So the nerves are also injured because you are having a radical surgery involvement of the nodes. Plus the nodes are also positive. So you will have to have an adjuvant therapy. So the morbidity is going to be more if you're going to have two types of therapy. We want to have only single type of therapy. So that's why we want to have a node, you want to have a sentinel node biopsy, you want to use imaging. So you want to do the maximum therapy with one modality itself. Okay.
Yes.
If you're going to have multiple modalities, then it is going to be, morbidity is going to be more.
Yes.
Okay.
Yes.
Okay, now we have finished about surgery, radiotherapy, complications. Supposing it's a very advanced disease, what will you do?
We have to go for
4A.
palliative treatment, ma'am. Chemo. Palliative chemotherapy or chemo.
What will you give? So what, supposing it's 4A, I'm saying there is involvement of the bladder as well as the rectum. So palliative chemoradiation, you're saying. So
Yes.
how will you give the radiotherapy in this?
Ma'am,
Most of the time it is only external beam radiotherapy. You're not going to go in for an intracavity radiotherapy for when it is going to be 4A and all. Okay. You're just going to go in for an external beam radiotherapy. It is only palliation. It is not going to increase the survival of the patient. Okay.
Yes.
And what are the surgeries you are having? What are the surgeries? Advanced surgeries?
Pelvic extended radical.
Advanced surgeries. What?
For advanced stage, ma'am.
Pelvic excentrations, anterior and posterior also.
Yes.
No. I'm just asking what are the palliative modes of surgery? What are the in advanced stages?
Extended radical hysterectomy.
Advanced stages, you have anterior.
Pelvic excentrate.
Yeah, pelvic excentrate. What are the principles of pelvic excentrate?
The pelvic side walls and vulva, everything will be removed.
There is anterior and posterior, right? For which you will go for anterior and which stage you will go for posterior and central. All those things are there, right?
Gone to this. You have to, whatever you the questions which you're not able to read, your answer, you will have to go and read in depth as a postgraduate so that for your further exams. Okay, now we'll just go in for, just we have finished the discussion on CA cervix. I just want to go into the modes of screening also.
Yes.
Okay.
Yes.
Now tell me, you said that you want to, Madam was telling, President Madam TNFOG was telling about elimination of cervical cancer. Can you eliminate cervical cancer?
Yes, ma'am. That's by 2000. The WHO has laid down the 2030 protocol. In this 90-70-90 ratio.
What do you mean by elimination? When will you call the cancer cervix is eliminated? What is the goal WHO which has set up?
Yes, ma'am. WHO has given the goal that at least 90% of the.
No, that is a method. No, that is a method. What is the goal? Goal is to have a to have an incident rate of incidence. What should be the incidence to call it cervical cancer is eliminated? So if you have an incidence of less than 4 per 100,000 population, then you say the cancer is eliminated, and this achievement or this goal has to be achieved by 2030. And so it is given a way of achieving it by saying 90, 70 and 90. What do you mean by 90, 70 and 90?
90-70, at least 90% of the age group between 9 to 14 should be vaccinated, ma'am. At least 70% of the CA cervix should be diagnosed in an early stage, and at least 90% of those who are affected.
Not diagnosed.
At least 90% of the women should undergo the screening at least twice in their life.
That 70% is wrong. 90% of the
should undergo vaccination, ma'am.
What is 70? 70 means first 90% means that 9 to 14 years of age, all the eligible girls should have vaccination. 90% of the people should have vaccinated. Girls should be between 9 to 14 years. 70 is 70% of the people should be screened by the most effective method of screening. And what is the most effective method of screening advised by WHO?
HPV DNA.
HPV DNA should be the method of and that should be at least 70% would be screened. Okay. And what is the age group which they say that when should they be screened? 30 years of age. If you're going to use that method of HPV, 5 to 10 years, if you can, you have to screen. So sometimes
Ma'am, screening should start at least from 30 years of age.
Okay. Yeah, at least. Not at least. After 30, not less than 30. You want it to be after 30, not less than that.
Yes.
After 30. Okay. Next,
Yes.
what is 90? The next 90 is?
At least 90% of the people who are affected by 90% of the women who are affected by CH cervix should be effectively treated.
You are partly right, partly wrong. 90% of the people diagnosed with not only invasive disease, even persons with pre-invasive disease. Persons who have been diagnosed with pre-invasive lesions, like low-grade lesions or high-grade lesions also, should be treated by the most effective method. They should have a most effective method of treatment. And also invasive cancer should also have the most effective method of treatment, including palliative care. And also for pre-invasive cancer, it not only includes treatment, they should have adequate follow-up. If you are going to do all the things properly, the chain, the link, if the link is followed correctly, 90, 70, 90, by 2030, then you can eliminate. If you're going to have the breakage in the link anywhere, then you will not be able to do this. Okay.
Yes.
Okay. How do you give the vaccination? What are the types of vaccine? And what is the vaccination which is being given?
Ma'am, 3 types of vaccines, ma'am. One is bivalent, one is quadrivalent, one is nanovalent, ma'am. In India, bivalent and quadrivalent is available, ma'am. This vaccine is prescribed between...
Nanovalent is available.
Yes.
Nanovalent is also available.
Okay, ma'am.
In India. Okay. You can get it from here. You can also get it.
Yes.
Okay. Okay. But it's costly.
Yes, yes,
okay.
Ma'am. Between 9 to 14 years of girls, it should be the dosage is 2 doses, ma'am. 0, 6, ma'am, or 1 6, 0 6, ma'am. Or if the doses, second doses can be given up to 5 to 15 months, ma'am. Between 5 to 15 months. Yeah, between 14 to 25 years, this is catch-up vaccination, ma'am. In this, 3 doses has to be given, ma'am. 016 or 026 in nanovalent. But even
what
after
is the latest advised by WHO?
Ma'am, it can be given up to 45 years. Yes.
The latest by WHO single dose of vaccine, if it is started early, it is enough. That is the latest 2022. They have said that even single dose is enough. But we have to wait for the results to say. WHO says even single dose of vaccination started early, not late.
Okay. Yes.
Okay. Supposing if we are vaccinated, can you stop screening?
No, ma'am. Since it is
Why?
type specific, ma'am, it cannot prevent against the other types, ma'am. So screening should continue as usual.
Okay, what are the methods of screening?
Ma'am, screening are three modalities. One is by HPV, one is by cytology, ma'am, and the other one is by pathological. One is see and treat, and the other one is screen and treat method.
What is the method which is followed in Tamil Nadu?
In Tamil Nadu, screen and treat method is followed.
No. What is the method of screening I'm asking?
Method of screening in the VIA is practiced.
You did tell about that in the screening. You told cytology, you told about the most common methods of screening in Tamil Nadu is VIA.
VIA.
Okay, what do you mean by VIA?
VIA is visual inspection of the cervix after applying the acetic acid.
What is the percentage of acetic acid which you have to use?
3 to 5% acetic acid.
What is the advice by now in our screening?
5%.
We are using 5%. We are using 5%. What is Villai?
Villai is visual inspection after application of Lugol iodine.
Okay. Okay, supposing you are finding what is low grade lesion and what is high grade lesion. Radha, should we complete it? Can we continue for 5 minutes?
You
5 more minutes?
You can take some more time, ma'am.
Okay.
CAN1 will come under the low grade lesion, ma'am. And CAN2 with the P16 negative, it will come under low grade lesion. If it is P16 positive, it will go under high grade lesion, and HCl will also go under high grade lesion, ma'am. And atypical squamous cell.
Okay, what do you mean by P16? How will you do P16?
Ma'am?
Will you do P16? How will you do P16?
P16 is by the liquid-based cytology method.
P16 is looking in for immunohistochemistry. It's not done so commonly. Tell about common things. Okay.
Yes.
So, till you are not able to do all these things, you take all the CIN2 also high grade lesions. What are the methods of management of low grade lesions?
Ma'am, if it is a low grade lesion, it can be followed up, ma'am, with either with the it should be followed up either with cytology or HPV after 1 year, ma'am. Even after 1 year, if it is persistent, if it is in one, it can be it can be followed up in 2 years. If it is persistent, then we have to treat either by ablation or excisional procedures, ma'am.
Okay.
If it is a high,
many a times it gets corrected, and so you need not treat many a times. Yes. But you will have to take the scenario as a whole. Okay.
Yes.
You will have to take the patient's age, criteria, all those things. Then you will take, and then you will tell whether they are going to follow up or whether you are going to treat. So how are you going to treat low grade lesions? What is the method of treatment? What do you mean by ablative treatment? Otherwise.
Ablative treatment, we have cryotherapy, ma'am, or leads or lead procedure, or thermocoagulation.
No.
Sorry, ma'am.
Leads or leads is an excision.
Yes, ma'am. For ablative therapy, we have cryotherapy, laser coagulation, and thermocoagulation.
Okay. Laser coagulation disadvantage is very costly.
Yes.
Okay. Yes. So, have you seen a thermocoagulation and cryocoagulation being done?
No, ma'am, in YouTube.
YouTube you have seen? No. That is enough.
Yes.
Okay. What is the mechanism of action in cryocautery and thermocoagulation, and what is the depth of destruction with thermo or the cryoablation?
Ma'am, depth of ablation is 5 mm, ma'am. In cryo, it will be with either carbon dioxide or nitrous oxide, ma'am. The freezing temperature, the tissues will be destructed, ma'am.
How?
With
what cycle we follow? Or is it, or how much time you freeze? All those things.
Yeah.
Freeze, thaw freeze method, ma'am. Okay. Freeze for the
3 minutes freeze and 5 minutes thaw.
3 minutes.
Okay. So what is the mechanism? It crystallizes the water, and so there is destruction. There is intracellular water which gets crystallized, and so it breaks up. So there is destruction. What happens in thermocoagulation?
The thermocoagulation, destruction of the tissues by the heat.
Okay. How much is the temperature with thermocoagulation? How much is the temperature with cryo?
In cryo, it's minus 80 degrees, ma'am. In thermo, it is 180.
180 100.
100.
100 to 120 centigrade. Okay, you will have to just, it's not 180 degrees, it's 100 to 120 centigrades. That's the temperature which they are using. And this is the OP procedure.
Yes, ma'am.
Okay, it can be done. And the time for using a thermocoagulator is less. You can suppose they were saying you will have to heat or they keep the probe over the lesion or the transformation zone where it is for at least 40 seconds. Before it was 42 seconds. Now they have reduced it to 22 seconds. So you can treat a patient in just 22 seconds. And this is the advantage over a cryo. One more thing with difference between cryo and thermal is you can have multiple applications. In thermo, whereas in a cryo, you have only one single application. So you can have, if there is a very large transformation zone which has to be treated, then they can use multiple applications on the cervix with the thermal. So this is the advantage. Only thing or the only disadvantage with ablative is that you don't have a tissue for a histopathological diagnosis. Supposing if the lesion is inside the cervical canal, then it is not adequate. This is not a method for treatment with ablation because it has gone into the cervical canal. You cannot put everything into the cervical canal. It should be entirely ectocervical and should be visible. And the lesion than 75% of the cervix, you don't do it. Okay. So how do you score lesions? What is the score which has been used for diagnosis of this intraepithelial lesions? You know any score?
Yes, ma'am. Sweet score and.
What are the components of sweet score?
The sweet score: margin, iodine uptake, astovite uptake, acetic acid uptake, and vessels, ma'am.
Lesion size?
Size of the lesion.
Lesion size. And also the vessels. So depending upon this, you have a scoring system, total of being 10. If the score is very less than 5, then you can go in for ablative method of treatment. If it is more than 8, you just do an excision type of therapy. 5 to 7, you have to take multiple biopsies and then decide on the treatment. So if it is going to be more, 8, how do you do the LEDs or the leaf procedure? What do you mean by the LEDs or the leaf?
Large loop excision of the whole transformation zone.
Large loop excision of the transformation zone. What do you do there?
Ma'am, if the lesion is more, we can go by the single pass or double pass method.
How do you do it? So this is done in a place where you have to give anesthesia, either
Yes,
local or you have to
the paracervical block has to be given. And after infiltrating with the local, we have to start it from.
No need to give paracervical. Here you give block over the cervix itself. Okay, like how we give the sentinel node, here you can give. Or you can give intravenous anesthesia by the anesthetist. What are the requirements for using this? What are the requirements for using this method of treatment? What do you need? Equipments. What are the equipments needed?
Ma'am, that loop diathermy machine, local xylocaine with or without adrenaline.
Main thing you need a speculum, which has got
which,
a vent.
yes, ma'am, speculum which has insulated speculum and also a smoke evacuation chamber.
One thing, now they are not recommending an insulated speculum. They need to have a speculum with a vent for evacuation of the smoke. No need to have an insulated because if there is any leak in the insulation or even small point, the electricity passes and you have a diathermy burns. Now they don't advise an insulated speculum. They want a speculum with a vent for evacuation of the smoke. Okay. Not insulated is not very much needed nowadays. Okay.
Okay.
So how will you control the bleeding after taking the loop?
After taking the loop by applying
after taking this, no, from the bed.
By applying
you can use the point at one, then can use, or you can use the Monsell space, which you already said, no, that also can be applied. Okay. Okay. How will you follow up a patient after treating? Supposing you are doing this pre-invasive cancer lesions, you are treating them. How will you follow up and how long will you follow up?
Ma'am, if it is a low-grade lesion, the patient will be followed up every year for the next 3 years, ma'am. If it is negative, if they proven to be negative, then they can go for age-related screening, ma'am. If it is a high-grade lesion, they has to be screened at 6 months and at 18 months.
Then how long will you follow them?
If,
Patient at 30 years of age. Okay. Then the margins are negative. How long will you follow her up?
ma'am, patient has to be followed up
Till?
for next 20 years, ma'am, till 65 years.
You need to have a follow-up at least for 20 years. Even if they are pre-invasive, you need to have a longer duration of follow-up, and yearly follow-up is advised, especially if you have treated, because the incidence of cervical cancer in a person who has been treated for a pre-invasive disease is 5 times more than the normal person. So you have to have an annual screening for them. And the method of screening, what is the method of follow-up? Which method would you like to have a follow-up?
It is by HPV and cytology.
What is available is cytology for us now. In the future, what is recommended or best is to have a HPV DNA typing. In the future, you need to have it, it's more sensitive. But if you don't have, you can have a dual method of doing a cytological screening.
Followed by
if you have facility, you do a colposcopy. It depends on what is the facility you have, but the patient should follow up at least for minimum of 20 years.
Yes.
Okay.
Yes.
Is it enough or you want some more questions? Good, Gauri, you answered most of the question. You should have brought some of your classmates to answer along with you. You have prepared well.
Thank you.
Madam, your student is very good, but she has prepared very well.
Excellent.
Madam.
Ma'am, you have covered, I think, almost the entire guidelines of cancer cervix, ma'am. Sumati ma'am, even I have learned some points from you.
Oh, thank you.
Very good, actually.
Your student has prepared very well, madam. Romba nalla padichirukanga. Gauri nalla padichirukka.
Excellent presentation by the postgraduate. Madam, only one question we have to ask.
Hello, madam. Can you hear me, madam? Sorry.
It is not.
So I had a lot of problem with my audio. Thank you so
No
much,
problem.
madam, for engaging our students very beautifully, madam. Because most of the time they cannot get to talk. That is the problem. It's new. They are the first batch, madam. So I think
she's very
thank
good,
you so
madam.
much, madam.
Very well.
Yes.
Even somebody has put a question for ablative method. Whatever be the method of treatment, whether it is ablative or an excision type of therapy, the patient should have a follow-up yearly. Because there is no universal guidelines to say that this is the method which you have to buy. Sometimes we pick it up even by some way or other. So it is better you have a follow-up. Most of the time, the patients will be positive within 24 months. Means most of the time, if they are positive, they will become positive within 24 months. So with ablation or with excision also. But anyhow, if to be on the safer side, the patient should have a follow-up at least for minimum of 20 years. We have started the unit in 2005. So we have patients who are coming from 2008 being treated with excision or something. For 14 years also they are coming. But that will be a bigger amount of people. 1 or 2 people will be coming for follow-up for 14 years. We would have not started treating for so many years, but there are people coming for follow-up for so many years. So it is always better that motivation is necessary. So if the people are not going to have a motivation, then they will not come for follow-up. And when you are just doing a screening and management for pre-invasive cancer, you will have to treat the patient as a whole, not the cervical disease alone. Some person is going to have a fibroid uterus and she's having a CIN2. We cannot do a LETS for her and just wait.
Actually, madam, this patient had abdominal mass also. She's not present today.
If there is a mass, then I asked, what will you do? She said it is pyometra. Supposing if it's pyometra.
No, madam, she had an adnexal mass, fibroid or something, she said. Yeah.
Okay. Then you could tell no. The patient, you could have told it in the meeting.
Yes, madam. For
Nothing
PG
can happen.
presentation, make it more complicated. Should not be a
You have
simple
to
case.
we will have to, supposing
She
it is
was
going to be case
worried,
selection
madam.
also.
First time, so she was feeling a little nervous. And yesterday we had a bad case, so
Okay.
something like a trolley or something,
Very
madam.
nice. Very nice.
First hand, madam, from you, from KGH, you are the expert, so it's good for them to know from.
Learned little bit by my teacher. That's it.
So such a lot of.
Very nice. You are preparing so well. You will have to continue like this. Keep preparing. Okay.
Yes.
Thank you so much, madam. Thank you, Radha, madam, also. Thanks a lot.
Madam, any more questions from the audience? In the chat box, only one is there. You have to-
Gauri,
Ma'am.
Tillai, somebody calls other PGs, no? Tillai Solle. She is one of the other PGs, madam. She also prepared. Just one question for her, otherwise she'll feel left out. Come, Tillai, va. One more, you can ask her, madam, something. You can ask her something. She also prepared a lot for this. You can ask her some question.
Aarti Pillai.
Aarti is
Okay,
our
okay.
professor. She's Tillai Nayagi. She's our one of the PGs, same PGs. PG, madam. You can ask her one
Gauri
question.
has not given any chance to her colleague. She answered all the questions.
Yeah, she prepared. She was very scared. She prepared really.
I was telling Gauri, you okay. Tillai, nee enna solle. Tell what you have prepared. Anything new, you have to tell.
Solle.
You are so much updated, reading so much.
Tell அவ ஏதாவது விட்டுருந்தா நீ சொல்லு.
Practicing, but you will have to tell what you have read. Something's new which we have not read. Tell me what are all the other oncogenic viruses.
Chal.
16, 18, 48, 33, 52, 58.
What are the things which are not covered by this nanovaccine? Nanovaccine has got 611, 8 nanovalent. And what are the other things which are available? 5 other components. And what are the things which are not covered?
Nanovalent vaccine covers 6, 11, 16, 18, 35, 52 and 58, ma'am.
Okay. Things which are not covered?
40. 39 is not covered.
Okay. Tell us something else. You went to Adyar Cancer Institute for training?
All of them.
Then you must have seen
do the CT mapping, no? CT mapping. And
What is that machine? What is the machine which they are using for HPV typing? What is that machine which they are using in Adyar Cancer Institute? They have a big machine, no? Hobas. Did you go to the preventive oncology department? Vijay Lakshmi madam is there, no? She has got a big machine, Cobas vaccine, where they are testing for high risk HPV. Did you go see that? You went only to the OG department, Malika madam.
Yes.
You should have gone to this preventive oncology where they are doing this HPV vaccination, how they are doing it, how it is computerized.
When we don't know, madam.
When your PGs are playing, you just go see. Okay.
Okay. Madam, you can include them for some webinars, madam, or PGs, if it's possible.
So, Sampath madam எல்லாத்தையும் coordinate பண்றாங்க.
எல்லாம்
Sampath madam
பண்றாங்க. இல்ல madam, KGH ல ஏதாவது something happens, you can tell us, madam.
Sure.
Online.
Madam, எல்லா போதனாலையும் எல்லாரையும் லாகின் பண்ண சொல்லுங்க மேடம்.
சரி மேடம், இனிமே they'll be do it, madam. They are all கொஞ்சம் அந்த ஸ்டார்டிங் ட்ரபிள் தான் மேடம்.
அவங்க அட்டெண்ட் பண்ணது கேன்சர் சர்விக்ஸ் கேட்டா 100 out of 100 வாங்க முடியும். அந்த மாதிரி எல்லாம் பண்ணிட்டாங்க சுமதி
மேடம். ஒண்ணு விடாம ஸ்டூடெண்ட்டுக்கு மேல அவங்க அவ்வளவு டயர்ட் ஆகாம கேட்டாங்க. இட்ஸ் வெரி இம்பார்ட்டன்ட் இல்ல மேடம், அவங்களுக்கு எக்ஸாம் மேடம்க்கு என்ன. தேங்க்யூ சோ மச் மேடம்.
மேடம் ஹேமா மேடம் இருக்காங்கல்ல, she was asking so much of questions, new things also. ஹேமா மேடம்
ஜெயஸ்ரீ மேம்.
ஜெயஸ்ரீ மேடம் மணக்குள விநாயகர்.
ஜெயஸ்ரீ மேம் நான் அவங்களை பேச விடல, அவங்க இன்னும் கொஞ்சம் நிறைய கேட்டிருப்பாங்க.
நீங்க கேளுங்க, ரீசன்ட் ஏதாவது கேளுங்க, ரீசன்ட் அட்வான்சஸ்
I think whatever recent is that elimination of cancer, what is more important in our country, we have to concentrate only on that, ma'am. Because this elimination of cancer cervix, I think that's what Sumati madam has asked. And screening, how we are doing in our country, in our state. I think those are the things which the students should know, rather than all this hi-fi robotic and this thing. That's only for the recent advances and theories.
Something much more like the quality of life and the less mutilating surgery, that kind of stuff.
One more thing, and in the Papak, how do you screen for HIV positive women also is there, the recent guidelines. So you should start screening by 30 years. For others, 30 years. For people with HIV, you will have to start screening by 25 years of age. And the screening interval also should be 3 years and not 5 years. Yes. For HIV positive women, you should start. Whereas for people otherwise, or the general population, it is 30 years and the screening should be by 5 years. 5 to 10 years can be the screening.
And why I've asked about robotic is because they've started robotic in Omandrar Medical College. I think one surgery has already happened in some other department. So I think there is a chance that these people may get in their...
Madam, but actually the Novak says an open laparotomy is better than minimally invasive. The studies have proven better survival rate, probably because of the tumor transmission. Because of
it depends,
and also the gas also.
Novak ma'am.
Yeah, madam.
Yeah, that's what they are seeing, how people are doing. No, what is it depends on the expertise, ma'am. Many people are not
no, the gas
in doing this
the tumor emboli, it seems, and also Novak, let's put like that, madam. Better than open is better than minimally invasive.
They are doing nowadays. They are doing in Raibata Hospital, surgical oncology department. Most of them it's done by laparoscopy.
Here also they do only lap, madam. Our onco-surgeons, they do it, but they are not gynecologists. It's just onco-surgeon. So he just, So
Madam,
we don't.
Shall I propose?
Yeah. Usually when the survival is better with gyne.
Yeah, but gynae onco-surgeon. Yeah. Quality of life especially.
Good evening, everybody who have logged in. On behalf of TNFOG, Dr. Anjalakshi, Dr. Sampath Kumari, I would like to thank Dr. Sumati and Dr. Jayashree, Dr. Bama and Dr. Aarti for coordinating, educating and inspiring the postgraduates. I think most of them will become gynec oncologists now. And I really thank Dr. Gauri and Tillai for preparing very well for this. Like you are prepared for your exams.
Yes, ma'am.
Presenting in detail everything. All the best in your future also. And I would like to thank Shield for offering this platform and enhancing the knowledge of all the gynecologists and the postgraduates. One thing I would like to add, madam, in all these things, counseling of the patient in every stage is very important. When we say radiotherapy, they'll think current vechiruvangala, and they'll be very scared. I think counseling and psychological counseling is very important each and every step, because they get demotivated with all this chemotherapy, radiotherapy and scarring of their skin and all that. I think lot of family support. I think we should counsel the family members more in addition to the patient, and take care of their psychology also, in addition to the normal modality of treatment. I thank Dr. Sumati and Dr. Jayashree for being here and getting us through the whole range of cancer cervix in all the treatment modalities, recent advances, screening. Hope we achieve the WHO goal. If not at least 2030, 2040 at least. Thank you very much.
Thank you, madam.
Thank you for the opportunity.
No. Actually, rather, I just want to pass on the information. The Tamil Nadu government has taken an initiative to start HPV screening in KGH. Already it is being done. It's already being done.
Madam.
Then, madam, all other colleges, madam, other medical colleges, madam.
You can send samples from there. Like you can send samples through the courier. It is a pilot project which has been. It will be coming in another 3 months or so. We are just starting. we are going to start screening with HPV, the best method. And you can send samples for screening and then you can send the report.
Excellent, excellent, madam. Wonderful. Because HPV screening is so costly, patients can't afford.
That is one thing. And also the government has taken an initiative. Vaccination
Vaccination
are
also
going to be
it will
vaccinated
be wonderful.
by 14 years. They are starting the vaccination for the
Oh.
Yeah, that is also being included in this year's agenda. We will be getting it soon. So two things are being taken as a pilot project, and then if it continues, then we can have an elimination by
2030 itself.
2030.
Tamil Nadu will be on top.
Everybody else has to continue the service. Whatever we have. Yeah, sure. Thank you.
Thank you very much.
Thank you very much.
Thank you, madam.
Thank you, everyone. Okay, madam.
Thank you, ma'am.
Thank you very much.